Dr. Denise Ejo, the CEO of Cornwall Cancer Foundation. I would like to welcome you to our Cornwall Cancer Foundation page. Our goal is to create an awareness of the challenges, support and guidance experienced in managing cancer care for sufferers, family, carers and friends. To engage with us, don't forget to subscribe to our channel. Click our notification bell. Good morning, everyone. Welcome to 2022. Happy New Year, and thank you for joining us again on this maiden 2022. Let's talk about it cancer awareness program. In the house today, we have got Dr. Adeoluwa Adeniji, who is an oncologist. And I will be talking through briefly about him. So I'll be giving you a brief of his bio and what we need to know about him. Before I start, I'd like to say thank you for joining us. Thank you for following us, and thank you for believing in our drive to create cancer awareness and spreading the word. A brief knowledge of who I am. I am the CEO of Cornwall Cancer Foundation. I live with cancer. I was diagnosed with cancer 5 years ago. I have had 9 brain surgeries removed, and it's breast cancer metastasis. So I am just trying to say I am very familiar with the journey. I am in the journey, but I am not a medic. I am a patient who is trying to create an awareness from my personal experience, so that together we fight, together we win. Today we've got Dr. Adeniji, who is a consultant clinical and radiation oncologist based in Lagos. Dr. Adeoluwa, let me translate. Dr. Adeniji is a board certified clinical and radiation oncologist with the West African College of Surgeons and National Postgraduate Medical College of Nigeria, with a strong passion for effective management and leadership, especially in the health sector. He's based in Lagos. In addition to this, he has earned a master's degree in human anatomy science from the University of Lagos. Dr. Adeoluwa has coordinated numerous research projects in oncology on screening, diagnosis, and treatment programs on both hospital and community levels, and has published articles both locally and internationally. Dr. Adeoluwa has also worked in a few specialist hospitals in Nigeria, in Lagos University Teaching Hospital. He was a full-time consultant at Lakeshore Cancer Center. He's also been at the Marcelo Ruth Cancer Center, and is which is also a specialist hospital. Dr. Adeoluwa, you know, with all your titles and all that, is very long. And I want to welcome you to, and thank you for joining us this morning. And we hope that we will be able to learn a lot of new things about how to take care of ourselves and help how to support others around who are going through cancer, who are not aware of what it is, and who are those that support those with cancer. So thank you for joining us, and thank you for your time. I will now hand over the platform to you, and anybody else. I'm looking at your messages and will collate it so that we can talk when he has finished. Thank you, Dr. Adeoluwa, and the floor is yours.
Thank you very much, Dr. Denise. I'm super grateful for the invitation, and also I would like to start by apologizing for the delay. We had some technical issues that needed to be sorted out. So quickly, I will go through a few slides just to guide. I strongly believe that when it comes to taking lecture, among people that are not really oncologists, it's better to discuss in such a way that they will be able to get it very well, and that will be determined mostly by the questions they're going to ask. So thank you very much this afternoon or morning, wherever you are, or evening. I will quickly go through the slides. So I'll be presenting cervical cancer. As you know, I'm Dr. Adeoluwa Adeniji. I'm a clinical and radiation oncologist, and I presently practice in Lagos, Nigeria. So a quick one. Okay. So introduction, cervical cancer, as we all know, develops in a woman's cervix. When we say cervix, okay, some distraction at the background. Okay, thank you. So a woman's cervix is what we call the neck of the womb, commonly. That's the way to describe it to people. Because we have the womb or the uterus, and then you have the entrance into the womb where the neck is. That's where the cervix is. And when you look at the cervix generally, just to briefly describe the anatomy in a way we can understand, when you look at the cervix, it has two parts. It's like there's the first half. Okay, there's the first half that looks very smooth in a way, and then the other half looks rough in a way. So there is a part, the midway between the smooth half of it and then the rough part of it, that it is called, it's a line, and that line is where commonly it's called the zone of transformation. So that zone of transformation where it changes from the smooth to the rough part is where commonly you have these problems called cervical cancer. That's where it develops from. And when it develops from it, most of the time, it doesn't just start out as cancer. It starts out as what we call the CIN, that's the cervical intraepithelial neoplasia. So commonly, it's not a full-blown cancer. And if it can be picked at that stage, it's very good, and surgery and some other treatments can come in to take care of it at that point. But once there is full transformation into cancer, then it becomes a full-blown cancer. So it's the fourth common cancer in women globally. There are cancers that we expect globally. You talk about the breast, you talk about the lung, you talk about the colon, then you also talk about the cervical cancer, and then of course endometrial is there. So, but in Nigeria, women commonly, it is the second cancer that you find after the breast cancer. Unlike when you go to the Western world, after breast cancer, you don't find cervical cancer there. What do you find? You find things like endometrial cancer coming on, usually even after, when we talk about after lungs and colon, as it were. But one thing I want to say at this point, the reason the Western world wouldn't have much of cervical cancer is because there's a high prevalence of vaccine. Vaccination is ongoing every time. And cervical cancer is one of the cancers that you can actually prevent. It's interesting that in sub-Saharan Africa rather, or in African countries generally, you will notice that the cancer you can prevent is now becoming the prevalent one, the one that is very common. So it means we are not paying much attention to prevention, and we are not paying much attention to vaccination. So things need to be changed. Things need to be reversed so that the cervical cancer can be prevented. And one of the things that were deliberated globally recently in the past 1 or 2 years is how to take the level of cervical cancer to zero in Africa especially. And then they were talking about the use of vaccines, which I am going to get to gradually. So, and mortality is more in sub-Saharan African countries. Why? Because there's no vaccination, no access to care, few specialists, the infrastructures that we really need and the trainings, they are not on ground. For example, in Nigeria, we'll be talking about having about 88 to 90 oncologists all over the country. There are many states in Nigeria where I'm based that do not have clinical and radiation oncologists. And the implication of that is that people in such states wouldn't have access to care early. And if they are going to get specialist care, they will need to travel to other states. The same thing applies to the treatment, including radiotherapy. So we have a long way to go in Africa. But in developed world, which some of us here practice or live in, a lot of things, things have improved a lot as regards cervical cancer. Most people there do not develop cervical cancer. So what are the causes and the risk factors? In cancer care generally, people ask, what are the causes of cancer? How can I prevent cancer? There are many cancers that we cannot really say these are the causes. But when it comes to two types of cancer, you can really say these are the major causes. Once you remove this, you can remove most of it. One of such cancer is cervical cancer. So there is an infection with a virus called human papilloma virus, especially the strain of 16 and 18. They are well known to cause malignant transformation, meaning that they are well known to cause cancer. When we say malignancy, it actually implies cancerous, appearance, as it were. There are many strains of HPV, human papilloma virus, but you find out that some of them will cause what is called benign lesions, not cancerous, but some of them will cause cancer or cancerous transformation. But the two that are notorious for this and well known for this is the strain 16 and strain 18, or we say the type 16 and the type 18, as it were. So it is a known cause of cervical cancer. Then another type of cancer that you can say, okay, there is a known cause is what we call the lung cancer, which is smoking. So smoking is a known cause of lung cancer. However, there are many other things that come in. They call them associated risk factors. Risk factors in the sense that once they are present, the chances of people developing such cancer types, the chances are very high. For example, in the case of cervical cancer, people that smoke, women that smoke, the risk factor is the diethyl silvestrol exposure, especially to the woman when she was in her mother's womb or unborn baby. So when mothers are exposed to diethyl silvestrol, that's DES, their babies are likely to develop cervical cancer later on in life. Then another thing which is well known is multiple sexual partners. These are all risk factors. People that have multiple sexual partners, they are likely to develop cervical cancer. And why is that so? Because the chances of being exposed to HPV virus or human papilloma virus is very high. And human papilloma virus is one of the sexually transmitted disease that we have. Then another risk factor is the multiple birth. People that have many experiences with birth. It's been postulated and explained theoretically in a way, and that's also been established through researches that there's a kind of trauma that takes place when babies keep coming down, the neck of the womb or the cervix. So as a result of that, later on in life, then there is transformation into malignancy. Of course, it's a risk factor. Risk factor means that everybody that is exposed to it will not develop, but the chance of individual that is exposed to such risk factor developing such cancer is very high. That's why they are called risk factor. Another risk factor is penile cancer in partners, especially in male partners, to be specific. So when a woman, have an intercourse or intimacy with a man that has developed penile cancer, because penile cancer is mainly caused by human papilloma virus also and some other causes. So the risk of that woman developing cervical cancer is very, very high. And then the last on the list is the immunosuppression. Immunosuppression, especially from the HIV. So when you see people that have HIV and they develop into full-blown AIDS, the chances that they are going to have cervical cancer in such women is very high. So all these are risk factors. So what are the symptoms? Mainly, it's very easy to know the symptoms. In fact, there are symptoms that are associated with the stage. They are based on the stage of the disease. However, before we start getting to to advanced stages, before we start getting to that, there is something that I would like us to know. Number one is the fact that the woman is going to experience some form of discharge. It can be bloody and may not be bloody. It can be smelly. It can be foul smelly. It can be associated with pain and so on and so forth. And then this discharge is commonly, if it is bloody, it can come in between the menstrual flow of the woman on a monthly basis, or when the woman is having intercourse or after intercourse. So these are common. And there are times that even the bleeding, the monthly physiological bleeding, that's the menstrual flow, may be heavier than expected. So these are possible, things that the woman can experience. Another thing is that they can be associated urine infection because the urethra is very close to the vagina and to the cervix. And also pain in the lower tummy can also be, a symptom as it were. So what are the common tests that we do? Many tests. Number one, you want to do the MRI. MRI is very sensitive then or CT scan. We call them the imaging investigation, just to know what is going on. Then the blood test to know if there's anything in the blood, or you may want to check the tumor marker CA125, or you may also want to check the general well-being of the woman during the full blood count, the kidney function, the liver function, and some other things. And then X-ray can also come in sometimes. And you also have some other tests, which I have listed, the intravenous pyelography, just to look at the urinary tract, or cystoscopy to look at the bladder, or colposcopy to look at the cervix, or proctoscopy just to look at, the rectum, as it were. PET scan too can come in depending on the stage of the disease. So this is the pictorial diagram, showing pictorial representation of the stages of cervical cancer. You can see the first one. You can see what we call the stage 1A1. It's not just straightforward like stage 1, stage 2. You have stage 1A1, which is very tiny, and it is microscopic in a way, in such a way that you need to look at it under the microscope to be able to tell one or two things, whether it's really there or not. And the beautiful thing about this is that this doesn't require much treatment. You can do surgery. You can also do some other treatment like cryotherapy and so on and so forth. And then it can move on to stage 2. You have stage 2A, stage, there are many stages. And stage 2 is when you cannot see the physical eyes, and then it's at the upper part of the vagina. Sometimes we say, okay, there's stage 2A1, stage 2AB, and then stage 3 is when it comes to the lower part of the vagina. You can see it has left the cervix. It's now invading the vagina. And then stage 4A is when it has invaded the bladder or the rectum, and stage 4D is when it has gone to other part of the body. We call it the distant spread. And in such case, we call it, very much advanced. And when it becomes very much advanced, it means we may not be able to cure it. So at that stage, we'll be talking about the palliative care, as it were. So treatment, in summary, the surgery can come in when it is very early in stage 1A1. Okay. Hello? Oh, okay. So surgery can come in when it is very early. And then when it gets to stage 1B or stage 2A, and then we'll begin to talk about the use of radiation. And radiation can be external, we call it external radiotherapy, or internal radiotherapy, which is also referred to as brachytherapy. So external radiotherapy, like the first machine I showed you, this is the machine of external beam radiotherapy. Then what happens is that the machine tries to capture larger surface of the tumor, covering the nodes, covering the tumor, and covering wherever it needs to be treated in the pelvic region and also the lower abdomen, as it were. So this external beam radiotherapy. Internal beam radiotherapy, which is brachytherapy, just means that we are treating the woman in a localized way, in such a way that we put a probe there containing the radioactive, the radioactive substance, and which now radiates. But at this point, it doesn't irradiate large surface, it irradiates the area that's surrounding the tumor. So we call it brachytherapy. So we use it for localized disease, or when the tumor is very small, because it doesn't go all around. It doesn't touch the surrounding areas as much as we have in external beam radiotherapy. And chemotherapy is another one, especially for advanced disease, when we are talking about palliative, or when the disease has gone to the lungs, gone to the liver, or other parts of the body, in the case of stage 4B. And immunotherapy is not the new one that is coming in. For example, we have new drugs that are coming in, immunotherapy such as pembrolizumab, and even some use of vaccine. So these things are being used now, to treat, because immunotherapy has been found to be useful for many types of cancer, and it has gone a long way in changing the story and the outcome of cancer patients. So I'm going to round off by talking about screening and prevention, because this is very important. Why do we do screening? We do screening to be able to pick disease before they become full-blown, when it is early, or we pick it when the signs are all over, so that we can prevent it. We can prevent it, and we can prevent the occurrence of the disease, number one, or we can prevent it from increasing in stage or becoming advanced. So one of the things that we need to do is that women with, when we screen, we pick what is called the CIN at the early stage. CIN is usually the cervical intraepithelial neoplasia, pardon the long term. So, but what it means is that there is a lesion, there is a problem within the cervix, and it's inside the layers of the cervix. But this time around, it is not cancerous. It is just what we call benign, that when it is removed, then there's no problem. But when it is not removed, the chance of it becoming transformed into a full-blown cancer, it's very high. And then HPV, who had removal of the cervix. So for the screening, generally, so what do? We screen women of any age, basically from 20, okay, we are going to get there. So women of any age don't need screening. They have had their cervix removed. And okay, this is just to guide what I'm about to say. Number one, women that have had surgery and they have removed their cervix, maybe they did hysterectomy and they removed their cervix, and they didn't have any problem with human papilloma virus infection previously, and then there is no also CIN, no cervical epithelial neoplasia before that. So they may not need screening because the cervix is removed, all the risk factors, they are gone. And so they don't need to be doing annual screening. But the one that have removed their womb, and then with the CIN there, with HPV infection, they have to do their annual screening, which we are going to talk about. Annual screening would include what? Annual gynecological examination. So they see the gynecologist who examines them annually just to look for the sign of the appearance of the disease. And then pap tests can be done for women every 3 years once they are 21 years old or older. So from now look at this trend. It's very important that you see this trend. So a woman that is 21 years old, young, and then or older, so they do only pap smear. You notice that it's only pap smear every 3 years. So they do that. But once they turn to 30, another test is introduced. And that other test is what is called the HPV test, human papilloma virus test. So you now have a combination of pap smear test and also HPV test, which is there now. Now, a lot of people are moving away from pap smear, so they are now doing what is called the cytology-based, testing, which is what is going on globally now. But in many countries are yet to develop, so people still stay with their pap smear test. So once the woman turns 30 up to 65, so they do pap smear test or cytology test and human papilloma DNA test. And then they do that every 5 years. Because they do it every 5 years, they do it together every 5 years. It's called co-testing. So because you're doing it together, co-testing every 5 years instead of every 3 years. So, but if the woman is not going to do the HPV test, so, and it's only pap smear test they will be doing, that will still be every 3 years, okay? Like what you have between 21 to 29 years old. So basically that is it. Then they do gynecological testing or examination. So let's talk about the major thing that the world is focusing on now, which is vaccines. There are different types of vaccines, and there is the one that we call the Gardasil, and then there's the one that we call the Cervarix. So why do we do Gardasil? We do Gardasil commonly from age 11 or 12 years. So, and then, but now the new recommendation is that it should come down to age 8 or 9 years. Why is that so? Because we found out that the exposure to sexual intercourse is now earlier than what it used to be. So a lady or a girl who is at the age of 9 years and who is exposed to intercourse and got infected, so it means that something needs to be done at that age. So it has been reduced now down to the age of 8 or 9 years, depending on the guidelines you're looking at. And then it continues up to 14 years. Usually we say 9 to 26 years. But now, because of the doses we give, we have spaced it, or it has been broken down into two categories. You now have the one of 9 to 14, where they have 2 doses. And then you're now talking about 15 to 26, where they can now have 3 doses, as it were, depending on what we are looking at. And now another thing which has also been added is that instead of just staying till, before it used to be 9 to 26, but now they found out that they can still salvage, some of this infection, because human papillomavirus, when it gets into the body, it doesn't cause cervical cancer immediately. It doesn't cause cervical cancer immediately. It stays for many years, changing a lot of things, affecting the cell cycle, trying to replicate itself within the host cells so that it can take over and then it can cause full-blown malignancy. But we now found out that even after some years, the infection can be cleared by the body system, by the immune system of the body, and there can be reinfection. So, and that was the basis for reintroducing, or for introducing the vaccine to the group age category of 27 to 45 years old now. And another thing which we also need to know that it's not only girls that are vaccinated. Now, there is now the Gardasil that can be given to both boys and girls. Why? Because if you can prevent a man from getting human papillomavirus infection, it means the man won't be able to give it, to the woman during the intercourse. The woman, it won't be able to give it to the woman during that. So you have the boys also are being vaccinated, not only the girls, even from age 9 years old. So Cervical is commonly given to girls, while Gardasil, that is now the one that is recommended, can be given to both boys and girls. And so on this note, so I'm going to say thank you for your attention, and I'll be so glad to take all the feedback, contribution, questions, and I'll be willing to answer them. Thank you very much.
Thank you, Doctor. Thank you. So we're going into the question and answers. So anybody that has any questions, you can put them in the chat box now, and we will start to take them. But I'm going to be starting with one or two that I have already received. One of the first questions, Doc, do you want to put your picture back on?
Okay.
We're looking at your presentation. Are you, okay.
I want to stop sharing.
Yes. Yeah, thank you.
Okay, thank you very much.
Thank you. Okay, so one of the first things, because we've actually also started this campaign on AIT as well, which we did last week. And one of the first things that we're trying to get very clear, and it's the main question that has come up again today, is HPV. What are the symptoms of HPV? Is HPV, is that not the vaccine? HPV is the vaccine, right? Or is that the name of
No, that's the virus, human papilloma virus.
All right, then you see, I've told you. Okay, so what are the symptoms of HPV and in young males?
Okay. Now, one of the things that we need to know about the human papilloma virus infection is that the infection is usually indolent. So it means that it can be in the blood and it will not produce symptoms for a long time. Why? Because the immune system of the body tries to fight it. So it only starts showing symptoms when the immune system cannot stop it anymore. So even when you find it in the boys, you don't usually have symptoms. You don't usually have, unlike what you have in some of the other sexually transmitted infections. So you begin to see much symptoms, and then you can go to the hospital and treat quickly. But this time around, it can be in the body for many years, even more than 10 years, and then nothing. And that's one of the major reasons we do screening. We do screening with HPV DNA test. So we just want to know, is there anyone with it? Because the person that has it, even though it's not showing symptoms, the lady is on her way or is likely to have more chances of developing the cancer. So you're not likely to have any major symptoms that can be ascribed to the human papillomavirus infection. Even in the boys, it is not common. It is not common at all. But however, because it's a sexually transmitted infection, it can present in a way that is similar to some other infection in a way when symptoms start showing. And symptoms of sexually transmitted infection include discharge, painful.
After a lot of challenges,
Okay. Okay, so it can have symptoms of sexually transmitted infection if at all it shows up. But I can tell you that once you see infection of human papilloma virus infection, you're not likely to see the symptoms immediately because the virus needs to go through some mechanism in the body to overcome the body immune system to be able to display symptoms or cause some form of transformation, as it were.
Thank you. So another question I'm going to now ask you is, the questions are still going back to this pap smear. Do you need to do a pap smear test if you are not sexually active?
Okay, when it comes, if you are not sexually active, number one, pap smear test is not to detect the presence of sexually transmitted infection. Now, I need to be able to make this very clear. The purpose of pap smear is to look at the cells of the cervix to know whether they have abnormal transformation or not. Like we said, that between above 85% of cases of cervical cancer, or let me just put it this way, people that are infected with HPV, and that's human papilloma virus infection, they have above 85% chances of developing, cervical cancer. But one thing they do is that apart from the human papilloma virus infection, which comes from sexual intercourse and is sexually transmitted, apart from that, there are other risk factors that can cause malignancy or cervical cancer. So meaning that even when you remove HPV virus, you still have about 10% to 15% chances of developing cervical cancer for women. So what we do is that we do pap smear just to look at the cells in the cervix to know whether those cells are looking abnormal or not. So a woman who is not sexually active, we still need to do screening regularly. We still need to do screening, but we call such women as low-risk women because number one, they don't have CIN, that's cervical epithelial neoplasia lesion, and number two, they don't have HPV infection, so they are low-risk category. However, they can do their pap smear regularly every 3 years, and sometimes they get to a particular age that will stop because they are low-risk women. Okay, but the reason we will not do pap smear is for a woman who has not had intercourse at all. Let's say the hymen is still intact, so it will be difficult to go and perforate the hymen. Otherwise, every woman needs to do pap smear for screening.
So am I hearing you saying that a woman who has not been sexually active, who has not done sex
at all, and the hymen is still intact?
How would I know an hymen? How would a woman?
Okay, because number one, gynecologists want to know if they need to go in or not. But if a woman's hymen is still intact, then there's no point going as much as possible doing pap smear because we need to go in to be able to take the sample.
Okay,
but a woman that is not sexually active at the time doesn't mean she hasn't had sex before. So because there are women that maybe the husband passed away and they are not sexually active at that point. So they still need to do pap smear. And once they don't have HPV infection, the screening for HPV may not really be there as it were. So they may not do the co-testing, but the complete screening is still the co-testing, HPV DNA test, and the pap smear test every 5 years from age 30 years and above.
Okay, thank you. I think I got it. So I'm going to differentiate it in layman language. If you're a virgin, no need. If you're not, there's need. Is that a good summary?
But let me just quickly say this. A virgin that can do pap smear should do pap smear. So because when we say virgin means different things. A woman's hymen may not be intact, may be off, and she's still a virgin, maybe due to exercise or some other reasons. So they can still go in at a particular age to do pap smear because there are other risk factors that can come in, like smoking and so on and so forth.
Okay.
So
based on what you've just said now, the first advice would be check with your doctors if you qualify to do a pap smear or not.
Yes, especially at the young age.
Exactly. Okay, another one I've got is, question is, can a woman of 29 and above, still the same thing, who is not sexually active, take the vaccine? Okay, this is different. Take the vaccine without doing the pap smear.
Without doing the pap smear.
Yes.
Okay, vaccine is to prevent. Pap smear is to screen. So the role they play is not the same in the screening and prevention. So a woman that is 29 years old and above, who is not sexually active, but has had intercourse before, can still do, can still take vaccine, because there is the new category of 27 to 45 years old. We call it, is like a salvage category. Just let's see how much we can prevent, even though it may not be 100%. That's what that age group is. So you can still take vaccine, but the part of the pap smear, without doing pap smear is to look at the cells, while the vaccine is to prevent the infection or prevent the virus from, becoming a full-blown, problem in the body.
Okay. Next question I have for you is, can a woman in her early 40s previously diagnosed with CIN, I don't know what that is, to benefit from the vaccine? So I believe you know what CIN is. Can you tell us what
Yes, that's cervical intraepithelial neoplasia, grade 2, because we have the grade 1, 2, 3. So, and now this is interesting. Number one, the purpose of vaccine needs to be, I need to emphasize that again, is to prevent mainly, and also as much as possible to prevent the conversion from what it is now to a full-blown problem. So if a woman is in her 40s, the likelihood that the vaccine is not going to, if she has had infection with HPV, vaccine is to work on HPV, okay, and not really on the CIN. So if there was previous diagnosis of CIN2, and then the woman is in her 40s, what the woman needs more? Let me just quickly digress before I answer. What the woman needs more is more of screening. Screening with cytology, pap smear, and also the HPV DNA test. That's what she needs more. But in terms of vaccine, if she takes the vaccine, if she has had HPV infection in the past, the vaccine may not be that useful in that age category. However, we cannot say, never. So just to fulfill all righteousness, because up to 45 years old can still have it for salvage category, then we can go ahead and give it. But it may not do much at that age to prevent the HPV infection or prevent its conversion to a full-blown one.
Okay. Now, can I ask you a question? This one has just...
Please go ahead.
I've just remembered this now. A woman who has had a hysterectomy does not need to have this thing anymore, right? Screening.
Yes and no.
Okay.
Yes, if the woman did not have any of the risk factors to develop cervical cancer. For example, let's say a woman had CIN grade 2 or grade 3, and after that, the surgeon or the doctors or physicians this time around, because there are many doctors like you are, you're also a doctor, but so let me use the word, physician recommended hysterectomy. But that CIN2 or 3 is a risk factor for developing cervical cancer. Or a woman that has had previously infection with HPV, even though has had hysterectomy for any reason, those risk factors are still there. So the woman will still need to do screening, especially with gynecological examination. So they still need to do screening. They need to do annual gynecological examination, which is part of the screening and prevention exercise. But if the woman had hysterectomy and did not have any of these risk factors that can lead to the development of cervical cancer, then the woman may not need to do this screening.
Okay, so you are saying that because there was a risk factor, which was what negated the discussion about having the screening, right, is where it's relevant.
Yes.
But if you were just ordinarily not very well with maybe period pains or whatever, and you had a hysterectomy, then you do not need the screening. Is that correct?
Yes, hysterectomy that's a complete one, total, that removed the cervix at the same time, not just the womb. Then it's not needed once the risk factors are not there.
Okay. So those of us that don't know what that is, well, we'll have to go and find out with our doctors.
Which one?
I'm going to ask whether we've done which one we've done now. A lot of women women have had hysterectomies for one reason or the other. And the general knowledge is that once you've had a hysterectomy, you really don't need to have any more of this, because you didn't have a hysterectomy as a result of either being having the virus because it's hereditary or whatever. You actually had a hysterectomy because of medical conditions that were, yeah. So a lot of us women who would have done it and just felt, you know what, we've done this thing and we've moved on with our lives. You are saying to us that no, we should still be doing yes.
Well, if you've done hysterectomy and they've removed the cervix, and there are risk factors for developing cervical cancer, you mainly need gynecological examination. So they check and see, is there anything we need to notice, especially in the vaginal part or the pouch, the cervical pouch that was closed. So because the cancer can still appear from those places.
Yeah, so that's what I'm saying. So that means we should actually be seeking advice from our doctors or mentioning that, can we get this done? Okay, thank you, because some of us don't know. Is there any age limit for the HPV DNA testing, irrespective of their gynecological history, especially those who have been screened?
Okay, for the HPV DNA testing, commonly in the low risk category, so what we do is that they continue until they are age 65, up to between 65 to 70, yes, and then you can stop. But in the high risk category, so we believe that they will continue as long as they are alive. High risk categories means they probably had issue with CIN3 or HPV infection is there, and there are all these risk factors which I have listed, and we know that the likelihood of the woman developing cervical cancer is very high. Even when they get to the age that people stop at age 65 to 70, they still continue, the test because the infection is there in the body.
Okay, there's another one here. Thank you, doctor. Is cervical cancer vaccine readily available across Nigeria? And if yes, how much does it cost? Is it covered? Okay, this one has a lot of questions. I don't know if you can answer them or if there's anybody in the house that can help us with them. How much does it cost? Is it covered by NHIS? And how can you rate the effectiveness of the vaccine? Well, I can comment on one because I'm an advocate for vaccines. On the last one, I know a lot of people that have taken that vaccine, and I think that when they're very young, the one you take from the age of 9.
Yes.
So I do know that it's something that is driven globally, and I think Nigeria, we're really seriously trying to drive that one now. So, but is it covered in NHIS? Do you know if it's covered? Okay, thank you.
Thank you for the question. The vaccine in Nigeria is not readily available nationally. Let me put it that way. But in some parts of the country, you can find it easily, like Lagos. And the ones I'm aware of is being, championed by the private sectors. The NGOs, the private hospitals, oncology care centers especially. So they offer it for a fee. I'm not too sure of the current fee now, but I know there are centers. For example, I worked in Lakeshore before. Lakeshore does that, and they have their fixed amount of money for that. So, and then there are other centers too that you can find it easily in Lagos. But NHIS, I'm not, to the best of my knowledge, it's not part of the NHIS global vaccine, program. Not yet.
Yeah, I think there was a conversation about it, and they're saying that it's not. I'm trying to see if the president of the National Cancer Association is on. If he is, I was going to ask him. Okay, he's not there. I can't find him. Okay. Okay, thank you. So it's not covered, and the cost varies depending on where you're having the vaccine, right?
Exactly.
Okay. What? Okay, let me not ask you that because I don't understand why vaccine prices are different everywhere. So where can the vaccines be held? You've answered that, general to everyone. What is the state of the vaccine in Nigeria, the program in Nigeria? In my experience, I never hear it discussed. Is it only privately available? I know the national president was on. I wish he's still on because he could have helped us answer some of these questions. I think he's left now. All right. Yeah, I think he's left now. Can you answer that question? Because that's a national drive. I don't know if there's anybody online who can answer that question because it's a national drive. So if there is, please, can you just put up your hand and then help us because we're trying to drive this one. No, we don't. Doc, do you know the answer to that?
The last time it was in the discussion phase because, you know, all over globally, cervical cancer was meant to be driven to zero level, especially in sub-Saharan Africa. Yeah. So it was in the conversation then, but it has not been implemented to the nobody is going to say, okay, you can go anywhere to any government hospital and have Gardasil or Cervarix now. I've not heard of that.
Yeah, thank you. So I know that we've been discussing it, but I don't think we've gotten very far. There's a question here that I needed to ask you. Yes, this is a question that has always come up. Does the vaccine have anything to do with fertility? Yeah, this question tends to come up a lot.
Well, the vaccine, fertility inhibition, right?
Yeah.
Or causing infertility. The vaccine, usually, a lot of researches have been done, and there has not been any significant reason as on the part of the infertility to stop it. So a lot of women have had it and they are not having issues with fertility. So I don't think that should be a problem. It is not, as far as we are concerned.
Okay, thank you. Yes. I know that I've got a comment here that there's a risk, one of the major risk factors of cervical cancer is smoking. Is that included in the campaign? I'm not sure it is. Well, I think that will be one of the conversations we can take back to the National Cancer Society for further discussion on this one.
Okay, can I say something on that?
Yes, you can, please, because that one is also, yeah.
Yes, smoking generally is related to many types of cancer. Many, not only cervical cancer. The reason we pay more attention to smoking in lung cancer is because it is a major cause, not just a risk factor. And when we come down to cervical cancer, you will see that we pay more attention to HPV because human papillomavirus infection is a major cause in cervical cancer. Every other thing is a risk factor. The same way you have other things that are risk factors for lung cancer and so on and so forth. So the campaign against smoking, we go around in, you know, shaping and affecting all types, many types of cancer, and not only cervical cancer. And in the case of cervical cancer, it's a known risk factor, not really a causative factor, as it were.
Okay, I get it now. Okay, I've got one more question for you, and that one says, have there, apart from vaccinations, have any natural remedies been touted or proven anywhere in the world?
Anywhere in the world? Yeah. Okay. When it comes to natural remedies, I know there are many schools of thoughts, and commonly we physicians stay with what has been researched, the studies that we have outcome. And most of these natural remedies, including the one that might have been claimed, you know, to be part of it, have not been researched. And some of them have been published in journals that you can't really take to the bank. So to the best of my knowledge, I'm not aware of any natural remedy to prevent cervical cancer, apart from the routine, you know, things that have been mentioned earlier on, the risk factors and what to do. Thank you.
I want to say a very big thank you. Let me just see, I've got one question and I'm going to take it, but I want to say very, very big thank you for this presentation. So let me see what it says. It says, it may seem not so serious, and so sorry, it may seem not so serious, but can smoke from cooking? Oh, interesting. Okay. From cooking with wood or burning, incense be a risk factor?
Okay, smoking can be of many types. What we found out to be the major thing in smoking, especially cigarettes and the other thing, is the nicotine component. Okay, nicotine so component and many other things are related to nicotine. So, but nevertheless, we need to know that the smoke from anything that is being burned can destroy the epithelial lining or the lining of the airway. And from there, there can now be transformation, which may lead to a form of cancer or problems. So it's always good to prevent inhaling much smoke because it damages the lining of the airspace.
Okay, Doc, thank you very, very much for a fantastic outing today. We really do appreciate it. I think we don't have any more questions and we don't have any hands up. So I am good to close. I want to say on behalf of Common Cancer Foundation, thank you very much for giving up your time to share this with us, especially at this time where we are becoming more aware of the challenges faced as a result of cancer, especially cervical cancer in women. So I want to say a very big thank you to you. I know we started off a bit late because we had technical issues, but that is standard and we're getting used to that. So thank you very much. To everybody on the platform, I want to say a very big thank you. Welcome to our first series of 2022. I think next month we will be talking with a general practitioner about the processes and how to find out if you have cancer and direct people to the right places to have an idea of the process of going through. And I think that person is a Dr. Timei. She will be joining us in February for our Let's Talk About It series. This year we have a packed full of events actually. And also from next week, we have Dr. Donyolo, who will be on AIT talking about cancer and mental health going forward. So we've got a lot of things going on. Keep an eye on Common Cancer Foundation. Our website has information. Instagram page, you'll find a lot of updates and facts that you can actually share with relatives. YouTube channel is now active and a lot of people are able to access it. So videos are out there from these conversations that people can share and help us make the cancer journey a lot easier for others to not be afraid, because this is not, cancer is real, but we have to help each other. So I want to say a very big thank you to all of you for joining us today, and we look forward to seeing you again next month, and it's the 3rd Saturday of February. The flyers will be out next week. Please register and we look forward to seeing you soon. Thank you. Common Cancer Foundation. Oh, World Cancer Day, we have a program on AIT with a panel of quite a few people who will be talking to us. And we are in partnership with, what's it called again? BioVenture, who will be having their president on AIT on the 4th of February. We look forward to seeing you all then. Take care of yourself. Thank you. Have a nice Saturday. Thank you, Doc. I will call you. You can unmute yourself now. Thank you very much for the invitation. Anybody can unmute themselves now.
Thank you. Bye-bye.
Thank you very much, Doctor.
Thank you. Bye.
Thank you.
Thank you. Bye.
Thank you, Doc.
Bye.
Thank you, everyone.
Thank you. Bye.
Have a wonderful weekend.
Thank you. We're grateful.
Thank you. Bye.
Thank you. Thank you, everybody.
Bye. Bye.